Hello, everyone. Welcome to this webinar. It is 2:30 now in Paris, so we can start this webinar. Maybe a few housekeeping rules before we properly start. So this webinar is set up as a normal Zoom meeting, as you may have noticed, which means that we can see each other and all the participants, which also means that you can unmute yourselves if you want to ask a question, and only after you have been given the floor, after you raised your hand. But we chose to have a normal Zoom meeting so that we can ensure participation and exchanges and discussions with all of the participants and not just among co-hosts. This webinar is an open webinar, which means that anyone can join. It's not just reserved to the IRDiRC members, even if it's most of the participants are IRDiRC members. We also have companies, we also have press. So thank you to everyone for joining. We will be discussing the results of the Rare Barometer survey on the diagnosis of people living with a rare disease. So that this webinar can go as smoothly as possible, please make sure that your microphone is muted. Also, we will be recording this webinar, and the recording will be later available online on YouTube. So feel free to leave your camera on and or off as you prefer. So we will have some time for questions and answers, but again, feel free to raise your hand or write in the chat if you have any questions or any comments to do on what is presented, and we will try to answer all the questions during the presentation so that you can have all the answers you need. And also you can use the chat, first of all, to introduce yourself, say hi, where you're coming from, where you're joining us from, and also for asking questions, unless you really want to speak up and ask for the floor by raising your hand. Please don't hesitate to ask questions in the chat. So we will give an in-depth presentation of the results of the survey on the diagnosis odyssey of people with a rare disease, so that you have everything you need to use the results in your advocacy work and your actions. So we will be together for 2 hours. The first hour, I will mostly speak and answer your questions based on the results that are presented in the peer-reviewed article that we published. And then on the second hour, I will give the floor to mostly to speakers who will present how they have been using the results in their own work. So just to be some context that most of you do know, the fact that many people with rare diseases remain either undiagnosed or misdiagnosed for years. That timely and accurate diagnosis is really essential to access to the right treatments and support, and ultimately to improve the quality of life of people with a rare disease. But diagnosis of rare diseases is often difficult and can take years, leading to significant delays in treatment and considerable challenges for patients, families, and healthcare systems. So there are a few policy goals that were already set either by the Rare 2030 Foresight study or by IRDiRC. And the goals are for people living with a rare disease to be diagnosed either from 6 months of coming to medical attention to 1 year of coming to medical attention. And we'll see that most of the time we're quite far from those policy goals. So as you were this, and so that we can reach those goals, we decided to see, first of all, what is the usual time, the average time to diagnosis, and how it could be improved. And to do that, we relied on the Rare Barometer program, which is our survey initiative to support evidence-based advocacy. And through this program that was set up quite some time ago, almost 10 years ago in 2016, we have developed the biggest survey that we had so far, and it was actually one of the first surveys we wanted to conduct as Rare Barometer from the beginning of the program, but it took really years to set up this survey. And the main goals were to measure the time necessary to obtain a diagnosis as rare disease patients, because several studies did that either in one specific country or on a few diseases, but we didn't have such a wide-scale survey on all rare diseases in several countries. Also, to understand the different steps of the diagnosis odyssey, to define the obstacles that limit access to diagnosis, to identify best practices, tools, and support and services contributing to a faster diagnosis, and to identify the role of new technologies with a specific focus on genetic testing for the diagnosis of rare diseases. So to shape the online questionnaire, we went stepwise, and we first conducted a literature review. Then we had an online panel in which more than 60 patient representatives participated, so that we could refine the concept of diagnosis and identify what was new in the field. Then we worked with a topic expert committee with which we identified the issues and the indicators that we wanted to include in the questionnaire so that it could be used on a regular basis. The results could be used on a regular basis. We also got the inputs from IRDiRC's Council of National Alliances and European Federations on the questionnaire itself. And we tested the questionnaire with a few patient representatives, and some of them also checked the final version of the questionnaire in their own languages. So the fieldwork was conducted in 2022 from March to June. And as I said, it is the biggest survey that was conducted by Rare Barometer so far, because we had more than 13,000 respondents worldwide and close to 10,500 in Europe. So we had also more languages than we usually do, and more countries represented, because we had an international pilot that was conducted with Rare Diseases International and the Global Commission to End the Diagnosis Odyssey for Children with a Rare Disease. And so that allowed us to reach out to more people in non-European countries. Even if it's not the results that I will present today, I will focus on the European results. But it also means that patient representatives in those countries outside Europe that had enough respondents could receive their results and use their results also in their country. So we will start with the first poll. Quick poll before getting really into the topic and describing the paper that was published in the European Journal of Human Genetics, and that presents the key results of the survey. In your opinion, so this peer-reviewed papers has already been read how many times online, or accessed by how many people online, knowing that it was published in May 2024, so less than a year ago? I see some people participating. We already have 30 participants in the poll, 31, 33, we're almost there. And so far, well, I think we can and the poll. Okay. Almost everyone participated. You should be able to see the results. So most of you think that the paper was read 300 or 600 times. Actually, it's been read, and you can see here, more than 9,000 times. So already 9,000 people have read, at least 9,000 people have read or have accessed the article online. So it really shows, I think, not only the scale of the survey and the interest that people share regarding the results of this survey, and that also explains why even after a few months, even a few months after the publication, we wanted to really go in depth into the results and make sure that people do understand the results and can use them as much as possible. Another aspect, as you can see, is that we do have quite a lot of co-authors, most of them being patient representatives. And that shows, and also, as I show here, just like the list, not only the list of co-authors, but the list of people we acknowledged in the article, the scope and the importance and all the work from several, the number of people that were involved in this survey, and that allowed us to really take it to the end and to deliver such robust results and significant results. So thank you to all of those who did contribute. So you have the goal of the study or the survey itself, but now the paper, we had to be a bit more specific than this big study because we needed in actually just 4 pages of written text to focus on the key points and the key messages we wanted to deliver. And the first one, the first goal was to estimate the time that is necessary to obtain a diagnosis for all people living with a rare disease in Europe, and to describe the difficulties that are associated with the diagnosis odyssey. The second goal was to identify the main determinants of the diagnostic delays. So we defined the diagnostic delays as being 1 year after symptom onset for people living with a rare disease in Europe, but also to look at those diagnostic delays, we wanted to go also a bit further and to differentiate the impact of patient delays, so of the time that is spent in the family before even contacting a healthcare professional about the symptoms of the rare disease, and the time that is spent in the healthcare system, because then actions that could be taken to shorten those 2 times are quite different. So to do that, to reach those 2 goals, we had to rely only on a subset of the respondents. So you see that we had more than 13,000 respondents worldwide. We removed, for methodological reason, non-European respondents, because you can imagine that the world outside Europe is quite wide, and having less than 3,000 people represented to, answering to represent all the rest of the world is not really that much. And we could not just focus on those countries that had enough respondents and a lot of respondents. So to make sure that the paper was really focused and relevant, we only considered European respondents. And among those European respondents, we only kept those who had a confirmed diagnosis, which means that we had to leave aside those who had just an initial diagnosis that was not confirmed with the appropriate diagnostic tests, or those who are still remaining undiagnosed. And then among those who with a confirmed diagnosis, who said that they had a confirmed diagnosis, we also kept only those who gave the dates of the symptom onset and of the confirmed diagnosis so that we could really measure and estimate the time that it took for them to have this confirmed diagnosis, which leaves us with a subset of respondents that we rely on in the paper of 6,507 respondents, which is still quite a lot, and that allows us to give a lot of robust results. So to sum up, what we have is the first study to investigate the time to diagnosis for people living with such a broad scope of rare diseases. We do have other surveys, but not representing such a broad scope of rare diseases in 41 European countries. But it has also limitations that are inherent to any declarative retrospective survey on rare diseases. First of all, we cannot estimate very precisely the recruitment bias that we may have, because to do that, we would need to know more about the population of people living with a rare disease, and we have too few epidemiological studies on rare diseases to do that. And another limitation is that this study does not allow to monitor the evolution of time to diagnosis over time, as it is subject to too many structural effects in a retrospective survey. So it means that we cannot capture the changing situations in Europe. Would it be coming from more advocacy and a better awareness of rare diseases, or to the fact that genetic tests, for instance, for rare genetic diseases are more and more available and increasingly realized at first intention. But already it really gives us a very good overview of how much time it takes and what are the difficulties to get to a diagnosis. So how did we do that? First of all, you see on the top right of the screen that there is a link, and we will also add this link in the chat, to the full questionnaire, so you can have access to all the questions that were asked. And in those questions, we used some to measure really to know when people had the first symptoms and noticed the first symptoms. So to measure the time to diagnosis, we consider that the very beginning of the diagnosis journey is when the first symptoms are noticed. And that's what asked by the question, when did you or a healthcare professional first notice the symptoms of the rare disease or thought that something was wrong? Then the end of the diagnosis odyssey is the moment when there is a confirmed diagnosis, which is when the name of the rare disease, syndrome, or malformation was confirmed by the appropriate genetic, clinical, medical imaging, molecular, or biochemical tests. So this duration between the first symptoms and the confirmed diagnosis is what we call the total diagnostic time. And we added another step in the paper, which is the first medical contact. And so the question was, when did you first seek medical help regarding the symptoms of the rare disease? And that additional step allowed us to make the difference between two times within the diagnosis journey. The first is the diagnostic time in the family, or what we call also in the paper, the patient delays, and the diagnostic time in the health system, or health system delays. So now that we know what we're talking about, let's have a first look at the time to diagnosis for all people with rare diseases in Europe. And you will find this time in the article, in the text, of course, but also in table 1. So you see in table 1, there is a lot more than what I show here, but at the very bottom of table 1, you have the average or mean diagnostic time for all the sample, for the 6,507 respondents. And so on average, it takes people living with a rare disease in Europe close to 5 years, 4.7 years to be diagnosed. What we also gave, we gave a few other figures, and those of you who are a bit versed into statistics will understand where I'm going with that. So we have the median time. The median time is what divides the sample in two. So 50% of the people who took less than this time to be diagnosed and 50% more than this time to be diagnosed. And the median time is at 9 months. So you see that it's quite faster. It's lower than the average time. The first quartile, which means that 25% of the respondents were diagnosed within 1 month, and 25% of them were diagnosed in more than 5 years, in at least 5 years. So for 25% of the respondents, it took really a lot of years to be diagnosed. So again, because I know that not all of you have the same statistical background, but some of you do need that information to present the results to their community or to people around them. It means that the distribution of this time to diagnosis is what we call non-normal. So what does it mean? It means that if you look at the histograms here of which percentage of people answered less than 0 years, from 0 to 0.1, which is 1 month, from 1 month to 1 year, from 1 year to 2 years, then 2 years, 3 years, 4 years, etc. You see that there are more people who answered at the left side of this graph than on the right side, and then it goes down gradually. If the distribution was normal, the curve would really look like the one that we have on the top left here. So it means that here the average time to diagnosis is closer to the third quartile. And that's something that is important in terms of statistics and that we took into account. And also that I need you to keep in mind, because for communication reasons, I will mostly use the average time, but just keep in mind that the average time to diagnosis is always closer to the third quartile than to the median. So we know that it takes on average 5 years, which is long. And for 25% of the population of people living with a rare disease, it's even longer than 5 years. And so if we look at the moment when people contacted a healthcare professional regarding the symptoms of the rare disease, on average, it is 5 months. So it means that the time spent in the family looking for, before contacting a healthcare professional regarding the symptoms, only represents 10% of this diagnosis journey. 90% is spent in the health system. So if we want to have a hint on where we can act to really shorten this time to diagnosis, the first thing would be to act on this time in the health system. So it means going to different types of, to a different audience. It's not just the general population, and making sure that people see that something is wrong and go see the doctor. It's really how we make sure that once we go see a doctor, time to diagnosis is shorter than it is currently. It also means that if we keep in mind the policy goals that we gave just at the beginning of this webinar, so 6 months from coming to medical attention, so the health system delays, or 1 year of coming to medical attention to get a diagnosis, most people actually in this sample, in this survey, were not diagnosed within 6 months, and almost only half were diagnosed within 1 year of coming to medical attention. So even when we look only at the health system, this is, we are really not reaching the policy goals. I may stop here for a short time to see if there are any questions in the chat. Okay, so it seems that I'm quite clear. Please don't hesitate if there's anything that you don't understand to say it in the chat and add questions in the chat. So the diagnosis odyssey is long and time to diagnosis on average is 5 years. But it is also difficult. So it's not only long, it's also difficult. And why is it difficult? Because quite a lot of people have to consult at least, well, several healthcare professionals. And here we see that 22% of the respondents had to consult at least 8 healthcare professionals before being diagnosed. 73% were misdiagnosed at least one time. And when we say 73% were misdiagnosed, in the misdiagnosis, we include the fact that symptoms were attributed to another physical disease, or that the symptoms were either neglected, not taken seriously, or considered as psychological. So at least, 73% of the respondents were misdiagnosed in one of those two ways at least one time. And 40% were not referred to a center of expertise, which we defined as a hospital unit that is specialized in a rare disease or in a group of rare diseases, which we will see also shortens the time to diagnosis, allows to have access to a diagnosis quicker when we are referred to a center of expertise. But those difficulties can be encountered. Well, of course, it's linked to the time to diagnosis, the fact that it takes so much time to be diagnosed. But those difficulties can also be encountered when we are diagnosed more quickly. So, for instance, even when people are diagnosed within 1 year, 28% of those who were diagnosed within 1 year consulted at least 5 healthcare professionals in a year. And 62% were also misdiagnosed at least one time in the time lapse of 1 year. And 38% were not referred to a center of expertise. So even if it shortens this time to diagnosis to be referred to a center of expertise, for instance, there are still quite a lot of people who were diagnosed quite quickly. You see that it's within the median time to be diagnosed, that still had a difficult diagnosis because they have to go through several consultations and misdiagnosis, one or several misdiagnoses. And these misdiagnoses, we ask the respondents to tell us, according to them, what were the consequences. And we can see that for most of them, in their opinion, there's been detrimental consequences of the misdiagnosis. So for 72%, if we take the pink and slight purple percentages, for 72%, they experienced a worsening of the symptoms. For 68%, the access to care was delayed. For 59% here, they could not access appropriate care, treatment, or surgery because of the misdiagnosis. And for 52%, still a majority, they received inappropriate care, treatment, or surgery because of the misdiagnosis. So that's among those who were misdiagnosed. Just checking the time. So I won't go too much into details into the genetic test. You have all the information that I was I'm going to give here in the paper. I just wanted to say also that we had a question on the changes that people noticed after accessing a diagnosis. And so if you see each consequences, what we call consequences, medical, financial, or social, you see that after the diagnosis, what has improved, which is in green here, is mostly linked to the medical consequences. So thankfully, it allowed them to understand how the disease will progress better for 60% of the respondents to access the most adapted care, treatment, or surgery, also to access clinical trials. But you see that only for a minority of people, and it improved financial or social aspects of their lives. And especially for the social life, you see that the diagnosis, and it's not so much the fact you have a diagnosis, and it's probably the fact that you access care and that you have to put a lot of energy into the care itself. But for a majority of the respondents, their social life worsened after they knew which disease they were living with and probably taking care of the symptoms and the disease itself. So again, I'm just checking if there are any questions or comments regarding those changes, because then we can move on to the next part of the presentation of the results, which are the main determinants of diagnostic delays. So here again, we had quite a lot of questions on how we ended up with those determinants and those characteristics of the patients and of the diseases that were the most impactful on the time to diagnosis. So we will just take some time to go through the methodology that we used to define those main determinants. And first of all, to already list the variables that we would include in a statistical model that we call a logistical regression, to see what was the impact of each characteristic on the time to diagnosis, to see what was the most impactful or a bit less impactful. So to do that, and because we had a lot of questions in that questionnaire and a lot of variables that we could use to see how much it impacted time to diagnosis, we had crossed the median time to diagnosis with those 70 variables that represent patients' sociodemographics and also diagnosis-related characteristics. And we kept the 20 variables that had significant p-values, meaning that they had a statistically significant link with the time to diagnosis, that it had an impact on it. And so you see on the right of the screen the list of variables that we included, so the list of determinants of the time to diagnosis. And interestingly and quite surprisingly, some of the usual determinants, health determinants, were not at all significant, did not significantly impact the time to diagnosis. So for instance, the CT size, it was in the questionnaire and it did not have a significant impact on the time to diagnosis. So if you live in a village, in a rural village, or in a big city, it seemed that the time to diagnosis was not significantly impacted. And that was surprising. The same for the level of education of the respondents. It did not impact time to diagnosis, and that's also a usual health determinant for more common diseases and access to care for more common diseases. Another variable that was not significantly impacting time to diagnosis was the point prevalence. So the fact that a disease is ultra rare, for instance, affecting only 1 over 1 million people, and point prevalence was not impacting time to diagnosis, as if, at least when we look at diagnosis and not care, access to care or treatment, rare is rare. So whether the disease is rare or ultra rare, the time to diagnosis is quite similar. And so that's also quite important to stress, because it means in terms of action that doctors probably don't think of is just all rare diseases and not just the ultra rare diseases. So in terms of communication and communication actions, that's also quite important to take into account. And lastly, we included into this regression only one time-related variable, which is the age of the patient when the symptoms were noticed. So I won't go too much into details into the methodological considerations here on the choice of this variable and why we didn't choose, for instance, the date of diagnosis if they were diagnosed more or less long ago, or for instance, their age at diagnosis. But you have all this information is in the supplementary file number 5, which is available online on where you can access the paper online. There is the supplementary file number 5 that explains why we kept only the age of the patient at perceived symptom onset. So there is also the gender of the patient, or the sex of the patient rather, the country group in Europe again, the number of healthcare professionals consulted, of course, it is linked, it is correlated, the fact that people were misdiagnosed or not, the fact that they had access to genetic tests, whether they have a genetic disease or not. We asked people also if it happened that they didn't have access to genetic tests or were limited in the access to genetic tests for different reasons. One was for financial reasons, or because it was not available in the country, or because healthcare professionals were reluctant or not sufficiently informed to prescribe genetic tests. And that's this only reason, healthcare professionals reluctant or not sufficiently informed, that was the only one that significantly impacted the time to diagnosis. So this is why it's the only one that is in there. And also the fact that the patient was referred to a center of expertise. We also have a few characteristics of the diagnosis journey from the family side. So the fact that a family member was already diagnosed with this same disease before the person responding or the patient was diagnosed. If financial support needs were met during diagnosis search, and if psychological support needs were met during the diagnosis search. And then a few characteristics of the rare disease and of its associated symptoms. So the number of body parts affected, which is an indicator of the complexity of the rare disease, but also the fact that the disease was genetic or not genetic, and a few types of diseases that did have either most of the time a shorter diagnostic time or more chance of a faster diagnosis. And they were skin diseases, gastroenterological diseases, gynecological diseases, renal diseases, odontological, we kept them just, there were a few of them, but we kept them still, neurological. Also, the fact that the symptoms were sudden onset of symptoms, acute symptoms, or outbreaks. So symptoms that come and go when or not always visible or not always present, for instance, when people go and see a doctor. And then, so those 20 variables were included into what we call an ordinal logistic regression. Well, 3 of them actually, because we wanted to see the impact of each variable, not only on the total diagnosis time, so on the diagnosis delays here, but also on the patient delays, so the time spent in the family and the time spent in the health system, to see if for some of those characteristics, the patient delays were more impactful than for others. So, spoiler, for most respondents, it's really the health system delays, the time spent in the health system, that is really more impactful. Only for children and adolescents, the patient delays are more important. And so in terms of action, we have to look more into what's happening in the families and the awareness of rare diseases in families, so in the general public, to shorten the time to diagnosis, because it's quite important for them. So one last consideration, methodological consideration. You see here that we see the odd ratios. So it means, for instance, that here for the age at perceived symptom onset, the shortest time to diagnosis, or those who have less risks of diagnostic delays, are people who are 50 and more when the symptoms appear. So we use them as a reference because that's the lowest time to diagnosis. And then we just compare them with all of the other age groups. And in terms of what it means, those figures, it means that, for instance, for the adolescents, for those who are between 10 and 19 when first symptoms appear, they have almost 5 times more risks to have a diagnostic that takes more than a year or more than 5 years. So it's really high. It's the highest, actually. It's the main determinant. So this is how we get which are the main determinants, how we end up with the results that I will present, by looking at the odd ratios and who has more risks to have a very long time to diagnosis. But so I will remind in the slides that will come the odd ratios and those risks. But what I will mostly rely on, and if you look for, if you want to find this information in the paper, you will find it in table 1. What I will mostly rely on, because it's more graphical and easier to understand, is the average value. So you have the average value here for all the people, for instance, who were less than 2 years old, between 2 and 9 years old at symptom onset. You see here that it's 4.9 years, 8.8 years, and you also have a median value, the first quartile and the last quartile, the third quartile. So you have this information in table 1 of the paper, but also all the information that I will show has been chosen based on the results of table 2, so of the multivariate regression. That really shows which are the most impactful characteristics on time to diagnosis. So as I said, and that was quite a surprise for us, the main determinant, the characteristics that impacts the most this access to diagnosis, is the age at first symptoms. And when patients or children, so between 2 and 10, or adolescents, it takes them years, really a lot of years, close to 9 for children and more than 10 for adolescents to have a diagnosis. And that was a surprise. That was a surprise even more that, as I said, not only did this delay come from the health system, but also from the family. And here we need to just look at that a bit and see that the first contact for children on average was done 1.5 year after the first symptoms. And for adolescents, it was even 3 years on average after the first symptoms. So so that we could explain that, we didn't have so much data in the survey itself to explain that. So we had to look in the existing literature on rare diseases for children and adolescents. And what we saw was that most of the time, parents are really presented as those looking for a diagnosis, initiating care, and they do have a very big impact, and they're very important for children and adolescents to have this diagnosis and access care. But also what we can see is that probably what is hard for them is to realize that there could be something really wrong. And sometimes we even have people who give us, who testimonied and said that they were in denial. We even had this mother who said that when she realized that her son was probably very ill with a very severe disease for a year, she was in denial. She didn't want to see that her son was that ill and that sick, and that it's just until there were some symptoms that she could not disregard because his teeth fell off before the usual age, and that's really a symptom of that disease. Then she could not be in denial anymore, and she had to look for a confirmed diagnosis, and she started again to look for a confirmed diagnosis a year after. We also had in the literature examples of adolescents, for instance, who felt shame. Well, first of all, did not always recognize symptoms because their body is changing. And so it took them time to differentiate normal changes to symptoms of their disease, or even just to talk about the symptoms that they did notice, either because they didn't want to face those problems or because they were ashamed. And that was especially the case in some where cancer or pediatric cancers affecting the gynecological parts of adolescence. They consulted only very, very late when they could not avoid it anymore, and because they felt ashamed. And so we can see that there's really a specificity here, and some of the results that I will present a bit later on may give us an idea on how we can accompany and help both the children, the adolescents, and their parents to probably go see a doctor a bit sooner and shorten this time to diagnosis. And that's probably through psychological support, actually, so that they can really process the emotions that will then allow them to take action and look for help for the rare disease. But the time spent in the health system is also very long, 7 years on average, and that time is even longer than for adults, would they be young adults or older adults. And that's also where we can act, and probably there are still difficulties for them to be heard, or for doctors to even consider the possibility that they would be really sick or ill at that young age. We also have seen a difference, a significant difference in time to diagnosis between men and women, and it takes longer for women. And so we did expect that result, actually. And the difference, again, is mostly coming from the health system. So the patient delays, they're a bit longer for women, but it's only weakly significant statistically. And most of the differences are coming from the health system. So this confirms some of the results that were found in other studies on rare diseases, especially one in France that was conducted on 2 different rare diseases, and where even when they controlled the gender-related prevalence of the diseases, that by analyzing only rare diseases that were similarly prevalent in both sexes, there was still a very big difference between women and women in access to diagnosis. And what we saw also is that, unfortunately, it's probably just a result of unequal access to healthcare for women in general. And for instance, there is a Danish study on almost 7 million men and women in the Danish healthcare system. And they've been followed for 21 years. And this study shows that for more than 700 conditions, women were diagnosed later than men, so even for common conditions. So there's probably an additional difficulty linked to the rarity of the diseases, of the rare disease, but that also shows that this is something that is happening also for common diseases, and that should be addressed in the health system in general. And how can it be addressed? We also looked at a scoping review that was published in 2020 that showed that gender disparities in specialized healthcare especially could be reduced or even eliminated sometimes if clinicians' adherence to guidelines increased. So it also means that we need to have guidelines, which for rare disease is sometimes difficult. But there are also a lack of studies addressing this problem in primary care, where the impact of narrowing gender bias could be even more significant. We also saw that when people were referred to a center of expertise, they were also diagnosed faster. So that's an easy recommendation, which is to improve referral to centers of expertise. Well, easy to say, not always to implement at national level, but at least when there are centers of expertise and people are referred to centers of expertise, it's still faster to have a diagnosis. On average, it's still 4.3 years, but it's still faster than when they are not referred to a center of expertise. Then we also had differences depending on the genetic nature of the disease. So it took longer for people with genetic conditions to be diagnosed. And that's probably the way the hypothesis that we gave was that it's probably because of the difficulty that people can have to access genetic tests, even if it's more and more prescribed in first intention. And actually, whether people ended up having a genetic disease or not, those who had genetic tests also took longer to diagnose. So that really calls for an easier access to genetic tests all across Europe, so that we can really reduce this gap between genetic and non-genetic conditions to access a confirmed diagnosis. And so, as I said a bit before, when I was listing the variables that we had, we also asked people if they were proposed financial support during their diagnosis search, and if they were proposed psychological support. And they had 5 possibilities to answer. Yes, and enough to cover my needs. Yes, but it was not needed. No, but it was not needed. And in that case, we considered that their needs were met. Either because they didn't need it, so it was okay, or because they had access to psychological support and financial support, and that was even enough to cover their needs. And but they could also say yes, but not enough to cover my needs, and no, but it was needed. And then we coded that, and we considered that their needs were unmet. And the results are that whenever their needs were met, would they be for financial support or psychological support, they had a faster access to diagnosis. But that impacted the time to access a diagnosis mostly in the health system. And so that was the first time that we saw those figures are at least presented like that. And that brought us to think that maybe the psychological support. So far we thought about psychological support so that people can really go through the difficulty of knowing which disease they're living with and really processing this information. But here now we can see it a bit differently, which is that probably when people have access to psychological support, as we said, a bit like for the children and adolescents in the family, that really helps them navigate the healthcare system, be able to deal with the emotions and then just focus on actions and to look for a diagnosis. Because even in the diagnosis search, when people do not have their sufficient psychological support, that just increases the time to diagnosis and access to diagnosis, and so of course access to care. So this is another action that can be taken to improve access to diagnosis, even when people don't yet know which disease they're living with. Another surprising result was, so we didn't look at specific countries, but your IRDiRC members who represent all rare diseases in one country do have access to their results. So you can either ask them if you were a national alliance or ask the national alliances to present their own results. But we use the grouping of European countries that exists and that was developed by the UN. And we looked at the average time to diagnosis for those sub-regions in Europe. And what we find was a bit striking. We didn't expect that. And even our members did not always expect that. It was that on average, it was longer in Western Europe and in Northern Europe to have a diagnosis. And so that allowed us to reflect a bit and see what it means to have an average value, or to look at all rare diseases at once in a country and see the time it takes to access a diagnosis for all those diseases, which can be very different. And what we ended up, and that's really taken from the article, is a consequence of what it means to use this measure of time to diagnosis as an indicator. And what we said was that, in our opinion, it should not be used just as a standalone indicator, because it has a few limitations. One of them is that, I mean, we measure what we can measure, and we don't measure what we cannot see or what we cannot have access to. And so probably the fact that we could probably explain, and that's something that could be verified, should be verified, that maybe the fact that the average time to diagnosis is higher in countries with health systems that are more developed, it may be because those diseases that are very complex and very long to diagnose are being diagnosed. And that, so if you have someone that is being diagnosed within 10 years, at least we have them here in the sample. And we may not, if they are still undiagnosed, we cannot have their time to diagnosis. So if someone in Eastern or Central Europe have a very complex disease that is still not yet diagnosed in those countries most of the time, then we don't have them answering and telling us how much time it took them to be diagnosed. So probably what it tells us here is that those countries from Western and Northern Europe have the means to end those very long diagnosis odysseys, because people can still go see a doctor and still be diagnosed years after the first symptoms and have access and know which disease they are living with. So as a consequence for action, and especially when there are national plans being set up, our advice is that the time to diagnosis should not be used at the national level or at the European level as a standalone indicator. We should not use only time to diagnosis. It can be used, but not only this measure. And not for all rare diseases in a geographical area. Because measured time to diagnosis, it may increase when rare diseases are better known and better managed in national healthcare systems, or when new diagnostic technologies allow to end more diagnostic odyssey. If we know at one point how to diagnose a rare disease, and people who were still undiagnosed for 15 years are diagnosed, then it will increase the average time, but that will be a good news for those who are being diagnosed in the end. And also, this measure does not include rare disease patients who are still waiting for a confirmed diagnosis. So, but if this measure is used by being coupled with a better understanding of the main determinants of diagnostic delays, then total diagnostic time is a robust indicator to inform policies and actions that could be taken to improve access to diagnosis for all people with a rare disease. And this is what we do here, and this is also what we'll present in the second part of this webinar with examples of uses of those results. So before we have a quick break and let all of you rest, and before that, if you have any questions, we will take them too. I will I just wanted to sum up the main results. So the diagnosis odyssey is long, close to 5 years on average, and 90% of this time is spent in the health system, even if time in the family is also key for children and adolescents. And it is difficult, this diagnosis odyssey. There are several consultations with healthcare professionals. Misdiagnosis is very common and has negative consequences on health, on access to care. And 40% of the respondents were not referred to a center of expertise. So as a consequence, we would recommend to prioritize actions in the health system by improving awareness of all rare diseases. For diagnosis, again, rare is rare. So all rare diseases among healthcare professionals, especially in primary care and among pediatricians, because of the longest time to diagnosis for children and adolescents, and to improve the referral to centers of expertise. We also saw that access to diagnosis improved access to healthcare, but not psychosocial support. And so we should improve access to holistic care or give access to more holistic care and improve public awareness of rare diseases to help improve social acceptance so that people can still live their full life after being diagnosed with a rare disease. And also, there are some additional difficulties encountered by some people with a rare disease. First of all, by children and adolescents, and that comes both from patient delays and health system delays. And to address the patient delays, so the time in the family, we can improve public awareness, but also awareness of healthcare professionals of rare diseases among children and adolescents. They can also be severely sick. Women take more time to be diagnosed, and thus mostly stems from healthcare systems. So again, that's a generality in healthcare, but still that could be addressed probably by considering the symptoms and improving adherence to guidelines, medical guidelines for girls and for women. People with rare genetic disorders, and probably because of the difficulty to access genetic tests, so improving access to effective and available genetic diagnostic technologies would allow to limit those differences. And psychological support, lack of access to psychological support mostly impacted the health system delays. And so we could improve access to psychological support even for undiagnosed patients. So I see that there is a question from Anna to know if the delays observed for genetic diseases could have confounded delays observed in children and adolescents. It should not, because of the choice that we did to have a logistical regression. So the results that we have here, it should be the impact of each individual variable. And the choice to have a logistical regression compared to just crossing each disease one by one with the time to diagnosis, that allows us to see what is the specific impact of each characteristics.
Thank you, Jessie.
That's really why we did that, because, for instance, we also had, at first, when we did the crossings, the one-to-one crossing with the time to diagnosis, for instance, we had invisible symptoms. It took longer for people with invisible symptoms to be diagnosed. But we also found that more women said that they had invisible symptoms than men. And so when we had, so that's why we really had a lot of statistical operations before getting to those final determinants, because in the end, that was probably a confounding factor, the fact to be a woman and to have invisible symptoms, because in the end we didn't keep the invisible symptoms as a main determinant, because it was not that impactful on the time to diagnosis, at least. But you see that in the lists, and I didn't give specific results too much on that variable, but in the list we also have the outbreaks, so the fact that symptoms come and go. That was more impactful than the fact that the symptoms were invisible in the end. Okay, well, we're quite on time, and unless there are other questions, please don't hesitate to raise your hand if you have a question. I think we could all do with a 5 minutes break before we get to how the results have already been used, and actually Anna will start with the Liselot. Well, no, I will first present a bit the fact sheets and the dashboards where there are some key results or in-depth results and how patient organizations can access them. And then I will give the floor to Anna and Liselot for the first presentation of how the results have been used. So we reconvene in just 5 minutes, if that's okay with everyone. So at 3:40, and to continue with this webinar. Thank you very much. So it is 3:40 now. I will continue with the presentation of other publications that we have had based on the results of the survey. So again, the peer-reviewed publication is really there to have an in-depth understanding and really go in these complex statistical operations that we did to end up with the main determinants, in addition to the average time to diagnosis and usual time to diagnosis. And we could not, in that publication, in that peer-reviewed publication, use all the steps that we had defined in the questionnaire for the diagnosis odyssey. We used only 3 of them, but we had 6 in the questionnaire. And those 6 steps, the 3 additional steps, are the initial diagnosis. So what we asked was when people first heard the name of the rare disease, syndrome, or malformation. Also the first symptomatic treatment, so when they received treatment, surgery, or care to help them manage the symptoms associated with the rare disease or caused by the rare disease. And the referral to a center of expertise, which is when they were first referred to a hospital unit specialized in the rare disease or a group of rare diseases as part of the diagnosis or care of the rare disease. And so what you will see in the fact sheet, so in the 2-pager that is available on our website, is this graph with those 6 steps, and that's also the graphs that our members, the IRDiRC members, so patient organizations that are members of IRDiRC can have access to if they have enough respondents. And so you see that on average, it takes 3.5 years to have the initial diagnosis, 3.6 years to have a first symptomatic treatment, and 3.8 years to be referred to a center of expertise. Of course, the order, well, not only the time to reach each of those steps, but also the order of those steps can change quite a lot depending on which community we are talking about, which disease, which country we are talking about, and we will see that in a few minutes. So among everything that I presented just before, and that is in the peer-reviewed article, we could not include everything in a fact sheet, and we wanted it to be very graphical and easy to use for our members when they go see either a doctor or politician or decision makers, but the main information is there. So the average time between the first symptoms and the first steps of the diagnosis odyssey, how much time it takes for people to be diagnosed and to reach each step of the diagnosis odyssey, how much time, which percentage is spent in the family or in the health system, but also the difficulties associated with the diagnostic odyssey. And we made a difference between the physical misdiagnosis and the psychological misdiagnosis. But also how many were not referred to a center of expertise or had a lot of consultations before having the diagnosis. And on the second page, and when the numbers allow it for our members, we also have the main results for depending on the age at first symptoms, on gender, and on access to center of expertise. We also have a dashboard, so you just have access. This is just one page of the dashboard, but this is all on our website. Again, you have the link here, tiny.cc/IRDiRC. And that's a dashboard that has more than 450 pages, so very detailed information. Again, our members can access their own, and they have access to all the information, almost all the information that is in the paper for European respondents, but also for their own community. And so who can access their own results in addition to European results? So EURDiRC members, so again, EURDiRC members are patient organizations. So EURDiRC members and European reference networks can have access to their results for their own community if they have at least 30 respondents. And when we say their own results, it means their fact sheet and their dashboard with the crossings that can be done with the number of respondents that they have to ensure anonymity. So we just wanted to show you an example of that will be given just later on HHT on what it means to have your own results. It means that we adapt the fact sheet really to your results. We adapt the graph, the time, but also the order of the steps, all the percentage of the time spent in the family in the health system, and the same for the percentages below. And of course, for the second page, when there are enough respondents, it's the same. It is all adapted. And the same goes for the dashboard. You see on the top, the European dashboard, and on the bottom, the one for HHT. And everything is updated with the right number of respondents and each responses of people in that community. So to have access to those dashboards, if you don't have them, or to the fact sheets, you can write to us at Rare Barometer at irdis.org. And then we will adapt them and send them to you, again, only to EURDiRC members and to ERNs. So for those, when I say at least 30 respondents, I also very quickly wanted to give an overview of who have enough respondents. So you see here, and you will receive later that presentation, the number of respondents per country, including outside Europe. You have here the number of respondents per country in Europe. And again, we will give you access to those to this presentation. The European federations, EURDiRC European federations, and the number of respondents. You see here that HHT had quite a lot of respondents, and also Myasthenia gravis, who will be presenting just after me. And by ERN. So we define the list of diseases by ERN with the ERNs themselves. And we give access to those results, not only to the coordinators, but also to the patient representatives, the EPAGs in the ERNs, and the project managers in the ERNs. And again, you will have either in the chat or in the PowerPoint presentation when we send it to you, the resources the link to those two resources to help you use the results. So the guide for the EURDiRC members, access and use your results, and also to an online course that we have developed with the Open Academy on how to do survey design for patient organizations. And I will now give the floor to Anna and Liselott to present. I see that the site can be reached. we'll have a look. I'll have a look at that during the presentation of Anna and Liselott. So regarding how they've been using the results of the survey for myasthenia gravis, and especially during the Rare Disease Connect in Neurology conference. Anna, I think you wanted to start.
Sure. Hi, everyone. Maybe we can just introduce ourselves first, Liselott, and then I can dive in. So my name is Anna Cole, and I'm Global Patient Engagement Lead for myasthenia gravis at UCB, a pharma company.
And I'm Liselott, an MG patient, and here representing the EU MGA, the European Organization of Myasthenia Gravis.
So as Jessie said, and as you can see on the slide here, I was introduced to Liselott and the EU MGA team in my first few years at UCB. And I wanted to give you maybe a bit of context before we dive into the details about how this survey was used. So first, maybe just to mention that before joining UCB, I actually worked in the IRDiRC team. And I say that not only to say hello to my fellow colleagues and obviously appreciate the work that they do and helps make the link, but maybe to just quickly add that one of our very first surveys at IRDiRC, and it wasn't around diagnosis, included myasthenia gravis. And I was very curious to see actually when this survey came out, what kind of progress we've made. And there has been, it's hard to compare, obviously, the two studies that were very different. But there has been progress, and maybe more importantly for all of you to understand the whole context, I think, of care and treatment for myasthenia gravis has transformed tremendously since that time, around 2006, 7, and 8. And that is, I think, due to a number of factors, which is that, of course, the unmet needs of patients has been more recognized. The unmet problem of diagnosis is one of those ones that has been recognized. The opportunities in science, of course, to address the disease have also progressed tremendously. And so there's been an influx, I think, of attention in the last few years around myasthenia gravis. And you'll see why that's important when I describe how we work together and why it was really important to kind of implement and use these findings with UCB and with the MG patient community. So as you can guess, UCB is researching this disease, and one of the many companies who are doing that in recent years. And when I joined the company and started learning about myasthenia gravis, which I know now is a neuroinflammatory disease with, as we heard, like a lot of, sorry, go ahead, Liselott.
Neuromuscular disease.
Neuromuscular and autoimmune disease. And as we heard, for a lot of rare diseases, it has, some of the similar characteristics of having very fluctuating symptoms, very hidden symptoms. And we'll go into the details, and Liselott will definitely let us know more from her experience, but obviously poses the same typical challenges for that reason for diagnosis. And more importantly, I think, as we get more attention, we also uncover how little we know, right? So with each survey, with each study, we realize that there's still a lot of uncertainty in our recognition of how it impacts patients, of their journey, and then, of course, how we can solve it. And so to make a kind of long story short, I think it was one of the things that motivated me and the team in presenting these results at the RDCN conference. So RDCN stands for Rare Disease Connect in Neurology, and it's a UCB-driven conference for the moment focusing on MG, because simply there was an identification that there was not really a good source of validated medical education for physicians. And it started out really just focusing on that audience. Slowly but surely, we realized that, of course, and some of us knew this more than others, that patient groups have a huge role to play in raising the awareness of the disease. And so they became a pivotal part, right, of that audience that now also includes nurses, which is an important healthcare provider, especially when it comes to treating and caring for MG. And so in the context of this conference, we brought both members of the EU MGA, but actually associations from all across the world. to come and to level set their knowledge about all of the evidence base we have around MG, of course, things that they live with every day. But what was a bit heterogeneous was the level maybe of exposure that they had to findings and surveys and publications like this one. And so that was really the main objective of the larger event, and specifically of the session around diagnosis. So as Lieselotte describes some of the specific findings and outcomes of delays in diagnosis and how they're different or similar to the global results that you just saw Jessie present, I think it will be, yeah, a kind of good inspiration, we hope, for all of you to realize the importance and the opportunity that these kind of company-driven congresses, and Lieselotte will give you many more examples of where they're using these great findings, whether it's the fact sheet, the article itself, or the dashboard. So we'll focus on this event itself, and in having leveraged all of those very easy to use materials. It was an opportunity to, as I said, level set the knowledge for all the patient groups, but actually a very unique opportunity within UCB and a lot of the physicians who we work with to recognize that there are some publications around there on the delays in diagnosis for myasthenia gravis, but actually the findings are not all the same. So both externally, when we see this, mismatch sometimes of the perception of how people live things as a patient versus how they might be observed by their clinicians, even internally in companies like UCB, we have some of that mismatch. So RDCN was really an opportunity to really add to the knowledge base around this disease and make sure that everything and every investigation that was done was captured, and really to demonstrate actually that sometimes the very patient-reported experiences and outcomes can drive down to the more clear details that we need to understand, because ultimately we were all there to find ways to overcome these delays. So maybe I will stop there and just show you the next slide, because there's nothing better than a picture to replace 1,000 words. So here you'll see the patient organizations who were invited and my dear colleagues at UCB, and you'll see a few more photos from Lieselotte, but just to show you that it's possible to bring something that's published in such a esteemed journal down to earth to 139, I think it was in total, physicians and 21 patient groups, and really start spreading the word about all of the great work and analysis that was done. Over to you, Lieselotte.
Thank you, Anna. Jessie, would you just continue to the next slide then? So here you see, for the first, I would like to say that in the MG community, we have for many, many years talked about the journey of our diagnosis, and it has always been conceived as a very long okay. Zoom just tells me that I'm talking in French. I don't know. Sorry.
No, that's definitely English. Don't worry.
Yeah. So the journey has been very long for us, but we have never had any real evidence saying so. So it has been very hard for us to get the attention of the physicians, and still we some of us get confused with psychologically symptoms and diagnosis in that area instead of the neuromuscular disease that is actually the case. So I would just like to say that we are very appreciative that we now have easy access to material that's actually published and evidence-based, because now we have a real gift that gives us the better base of discussion in overall terms. So how we use the results this last year. We had, of course, at the IRDiRC, we had a presentation in this group of the 21 patient organization represented, where we talked about the delays in the diagnosis and the quality that was missing in our travel or journey, and how it differs all over Europe, and how we can use examples from the countries where it's a little faster than in the rest of the countries, for instance. You can take the next slide as well, Jesse. So we talk about the different areas of how to go about it and how to educate our own community to get a better self-advocacy for awareness about MG. So we used it first in a presentation at the IRDiRC. We used it in group discussions, this data. And then we also actually used it at our summit to as a reference to what's going on and how to better use the data that we now have. And also to continue and to say that why is the patient organizations a thing that has to go on? Why is it important that we do the work as patients as well? Because this just shows that we can actually achieve something with patient data as well. And it's very nice that we have this. In myasthenia gravis, it's we have a diagnosis that affects women a little bit more than men in gender. And even though, as Jesse also just told you, there is still differences in when women get the diagnosis compared to the male gender. So we are also delayed. Then we also have the problem of getting the knowledge of experts and access to the expert centers all around. And even though this is a low number for us, 139, then it still gives us a picture of what's going on. And the last thing is that we used the material in the IRDiRC and had very nice 4 days of discussions. And then we're also going to use this material in our upcoming awareness campaign around MG and for getting more awareness about the delays in diagnosis and the journey itself. Yeah.
Maybe just to add a few last words in terms of how this was helpful. I can give a few, Liselott, and I know we've exchanged a lot, but I think it would be nice for everyone else to hear as well. So we described a bit of the differences in the delays, and although they're shorter, I guess, than the average, I think it's important to come back to your very opening, Jesse, in terms of the goals that we've set from ourselves in the larger rare disease community. And they don't come from nowhere, right? And I think the important thing to remember is that they've been set in that ambitious way because they're actually quite possible given the technology that we have. And so it's really important to recognize, as you said, that the delays in the healthcare system can be accelerated through communication and a lot of the other sort of efforts that you described could overcome them. But technically, we've seen it happen in other diseases, so technically they can happen, and probably even shorter, right, for MG. So even though it's kind of below the average, that doesn't necessarily mean that the job is done. And that's kind of the last point here in the presentation, which is that it's very important to look at specific results for specific diseases and the context. And part of that is the potential, right? And that's the whole point. If you can help people avoid all of this misdiagnosis, all of these unnecessary interventions, all of the quality of life impacts that I didn't actually mention, which I'm sure many of you will be familiar with in terms of all of the psychological struggles, socioeconomic struggles, all of these things that can be avoided if you just increase delays. So yeah, in terms of impact, just to repeat, I think internally it's helped a lot of my colleagues realize that the delays to diagnosis for MG can be even better understood than we thought in our sort of preliminary scoping reviews. And externally, this is just one example of a congress, in which case these tools have been made very easy to use, so that we can also externally ensure to raise awareness of all of those healthcare system professionals who can actually probably make a change in their daily practice. So thank you so much actually to EU-MGA for offering the opportunity to do that, because it is, as Liselott said, their dashboard and their super data that they're now going to use in many, many contexts. So hopefully this is just the beginning of how they can be helpful going forward.
Thank you, Anna and Liselott. Thank you very much. I will pass the floor, well, actually virtually, because Claudia Crocion, who is representing HHT Europe and who's been really involved in this survey from the very beginning, could not be here to present how she has been using the results, because she is at a medical consultation actually, but she recorded a message, and I should be able to share my screen with the sound so that you can hear what she has to say.
Absolute pleasure to be able to. Good afternoon. My name is Claudia, and it is an absolute pleasure to be able to share the wonderful journey we have had in using the information from the Rare Barometer study on delay in diagnosis. We wanted to just introduce our rare disease because it is absolutely fundamental to understand how the information from the survey was so important for our actions as a patient organization. So first of all, HHT stands for hereditary hemorrhagic telangiectasia. It affects 1 in 5,000 people worldwide. One very particular thing about HHT is that the only visible symptom that we have is quite misleading. It's a nosebleed. So over 90% of HHT patients have nosebleeds, and that is really the recurrent element for almost all of us. Yet there are many other implications of the disease. I can imagine you all can relate to the fact that it's absolutely rare that a GP or a specialist would raise a red flag over a nosebleed. Therefore, you will understand the next point, which is that evidence shows that approximately only 10% of patients with HHT actually have a diagnosis. Probably data is a little bit increased over the years, so we're probably over that 10%. But the last evidence was around that average, which is quite concerning, especially because HHT does not have a cure. It does not have a huge amount of therapeutic options, but it does have preventive measures. For instance, it has surgery for everything that regards avoiding brain abscesses, avoiding strokes. So there are many, many behaviors and interventions that can give a patient a much better quality of life. Therefore, when the survey from Rare Barometer appeared, we took it into much greater consideration than others because it was one of our main missions over the last 20 years to improve the levels of diagnosis. When I say we, I mean HHT Italy and all of the member states of HHT Europe, which is our federation. So our commitment to the Rare Barometer survey was huge, and we encouraged our population to participate in over the entire time that they had available, and the results were quite amazing for us. As a matter of fact, we had over 458 respondents in Europe. And that was extraordinary because it was the first time we actually pushed so much. And I think we were the first community as in number of respondents. What we didn't realize back then, and that today has been so life-changing for our organizations, is how this information would have impacted our work. Often we participate in surveys, we take a look at the results, but we don't really use it in very effective ways. We participated in many other things, but here we were so grasped by the topic that we received the dashboard with over 450 pages of information, extraordinary information, that we sat down and we did our homework. We didn't only look at the big numbers, we really went in depth to see what had statistic value and what this data was telling us. So across Europe, we had a different penetrance of the participation of the patient organizations, but in particular in Italy, where I reside and where I work also with the organization, we had 145 respondents, which was quite a considerable amount. So we specifically have worked in the last year on that data. And as of now, we have a scientific paper that is about to be published on the topic, but before that, we presented the results of the Rare Barometer study at the 50th International Scientific Conference that was just held in October with a poster entitled Emerging Factors Affecting Diagnostic Delay in HHT. We were very lucky because we already had a study in 2010, I think 2009, 2010, that had already analyzed some aspects on a cohort of more or less the same amount of people. So we were able to do also a comparison where we were in 2009, the average time DTL, which was diagnosis time lag, was approximately 25 years, and reach 2020 and see that things had improved considerably. We'll see how. There were two elements that we took into consideration and that I would like to share with you because I think they would be extremely important if you're analyzing this in the future. One is DTL, so the time between your onset of symptoms and the definite diagnosis. But there's another value that is extremely important, and it's RTL, referral time lag. The time between the onset of symptoms and referral to a physician. If you understand the difference between these two, which was extremely important for us, you'll analyze also where you have to intervene to improve situations. So just quickly, let's go to the findings. The good news was that the RTL and DTL for HHT had decreased incredibly, which for us was extraordinary. I'll just keep one example. Diagnostic delay was 25.7 years in 2009. We're down to 7.8 years in average. This is amazing news. We still have work to do, but we do have persisting obstacles. Index status, which is a paradox, but if a family already has a diagnosis of the disease in the family, the other family members actually have take longer to go and get checked, diagnosed, and followed in a center. Age of onset of symptoms, we realized that there was a huge delay still persisting for children and adolescents. As for gender, therefore women, what we noticed is that unfortunately, although the DTL, so the diagnostic time, is in average quite similar between men and women, the RTL is considerably higher for women. Therefore, what we have is women taking longer to be referred, so their symptoms are definitely underestimated. So how did we use this information? We didn't stop here. How are we going to apply this to our work as a patient organization? Well, every 3 years we do a strategic plan, and we were just working now in December and January on our 3-year plan 2025-2027. And one of our mission statements is reducing the gap in diagnosis. We've had this mission statement for 20 years. The general actions that we used, let's say from 2012 to 2024, were broad campaigns on HHT, pamphlets, training clinicians, press releases. But right now we have information that is so specific and so useful that we can actually study specific actions to remove the persisting obstacles for the delayed diagnosis. So for our new strategic plan, we have decided to work with the Society of Pediatricians in Italy and train them in order for them to have a better grasp of the disease and recognize it sooner, both in hospital setting and general pediatrician for families. We would like to promote and foster the creation of new pediatric centers because we only have one in the country. Having more than one on territories has proved to be extremely efficient from the Rare Barometer study information on HHT. What about gender? We know that there's a gender problem for referral. We're going to open a specific project to understand that phenomenon in more depth with a new survey for women in our communities, and maybe partnering with other diseases that have noticed the same kind of referral gap. So the gender gap in healthcare is a huge issue, and we will be addressing it with a further study. Last but not least, we realized that it was absolutely astonishing to see that families that already had a diagnosis were delaying the checks and diagnosis for other family members. They were privileged, they had a diagnosis. They weren't using the information, or the information wasn't coming across with the rest of the family members. So we've developed in our action plan a program that will accompany newly diagnosed families, that will create materials for their family members, that will have safe spaces for them to be able to discuss with peers from the patient organization, coaches from the centers, and if they prefer, also direct information and chats with geneticists. So what we're looking at is an action plan that also gives us the possibility to be extremely specific. Evidence-based action plans. We think this is absolutely compulsory, absolutely paramount. And we would like to thank Rare Barometer because we're learning how to use evidence in our action plans in a whole new way. So this is our contribution to this afternoon. I'm very sorry I'm not directly online today, but I would like to wish you all the best for the rest of the meeting. And if anybody has any questions, I will try to answer in the chat box if I can connect, or you can reach out to Rare Barometer through an email and I will answer your questions very willingly. Thank you. Absolute pleasure to be able to share the wonderful journey.
It started over again. So, well, that was, I think, a great presentation. So I want to thank Claudia not only for the presentation, but also for all the work that they did among HHT Europe and HHT Italy in using those results. I think it's really a very good example of how they can be used to really impact the strategic objectives an organization and define specific projects to address the difficulties that were seen in the results. Before going to the Global Commission, and I will be very quick before that, so I will give the floor to the colleagues from the Global Commission. I also just wanted, because that will be very short, to show you an example of an awareness campaign. So I'm sorry for the language, it's going to be in French, and we saw that so there will be subtitles, but there are some mistakes in the subtitles because they're automatic in English. But there is a campaign that is being led for 3 years now by the French National Alliance for Rare Disease Day on access to diagnosis, so awareness campaign to the general public, but also to pharmacies and healthcare professionals. And I wanted to show you a short film, 30 seconds, because I think that it's a very good example of how the results can be used without actually using the results. And actually they didn't use the results, they didn't rely on the results of the survey to build that campaign. But as one of the recommendations is to increase awareness of rare diseases among the general population, I thought that it was quite a good example. So because the subtitles are not very accurate, I still wanted to read in English the text that is read during that presentation. So again, it's on diagnosis, and it really tackles the different topics that are important for the diagnosis of rare diseases. So the text is, it's always the same story. First, you sense that something is wrong. You go to the doctor, he examines us, he says, come back if it doesn't go away. We come back, we prescribe tests, nothing happens. A year passes, then 2, then 5. You lose your self-confidence, your social life, your job, and after years of odyssey, you identify a rare disease. It's always the same story. Let's change it together. And then they have a call for action to call the hotline, the French hotline for rare diseases, and to visit Orphanet. So I will just share show you that very quickly. That short film, that 30-second short film, so that you can have an example of an awareness campaign for the general public that doesn't even have to use the numbers that we just gave and the results of the survey.
C'est toujours la même histoire.
D'abord, on sent que quelque chose ne va pas.
On va chez le médecin.
Il nous ausculte.
Et nous dit
« Revenez si ça passe pas ».
On revient.
Il nous prescrit des examens. Rien.
Un an passe, puis 2, puis 5.
On perd sa confiance en soi.
sa vie sociale.
Son boulot. Et après des années de souffrance, d'errance,
on identifie une maladie rare.
C'est toujours la même histoire.
Ensemble,
Changeons-la.
So I want to thank the French National Alliance for allowing me to talk about that campaign and give some more information that is in the slides that you will receive. And I will pass the floor. I see that they switched on their camera. So to the colleagues from the Global Commission, I will let you present yourself and let us know a bit more about the work of the Global Commission, which, as I remind, was really involved in the survey on diagnosis, and especially in the international pilot that allowed us to reach more people outside Europe than we ever did in a Rare Barometer survey. So up to you, Daniel and Toon.
Thanks, Jessie, and thanks for having us today. And indeed, we'll talk a bit more about the involvement of the Global Commission, not just in the survey, but also some of the work that we're doing beyond on the topic of diagnosis. I will not be doing that just by myself. I'm joined also by Danielle Dong from Sanofi. And I also wanted to recognize Rosaline Favres, who represents IRDiRC at our working group. So yeah, those are the contributors to to this presentation today. I'll start and then Danielle will follow on afterwards, showing some of the recent work the Global Commission has been engaging in. I'll give maybe an initial bit of a background about the Global Commission and how we contributed to the survey. So if you go to the next slide, you can see here a reminder about who are the members of the Global Commission, and a lot of those will be familiar faces to the rare disease community, obviously, but it's a truly global group, as you can see from the geographical representation, but also a multidisciplinary group representing researchers, physicians, patient advocates, innovators across the globe with a common cause to kind of shorten time to diagnosis. And maybe if I highlight kind of one of those, because a lot of those are obviously also involved in actual work and projects on diagnosis. And Danielle today will talk a bit more about Roberto Giuliani and some of the work happening in Brazil, where he's involved in a great case study on shortening time to diagnosis and the role of centers of excellence that you referred to, Jesse, earlier today, how important they are. So that's in terms of the membership. If we go to the next slide, just a quick reminder about the framework in which the Global Commission has been operating, and this should be familiar to most of you because we presented last year at ECRD about this as well, with the 3 pillars of work. Maybe just 3 highlights I wanted to give to this slide. The first one is around the mission. I think what differentiates the Global Commission is that we've always been looking at harnessing the power of innovation, and within that, really technology and digital technology. So that has been really a great focus of the work of the Global Commission. Secondly, maybe a bit more about how we've been involved in Rare Barometer in the survey that you explained very well today, Jesse, in a lot of detail. And I think a lot of great data points came out of that. Early on, the Global Commission got involved both quantitative and qualitatively in that survey. From a quantitative perspective, you already alluded to the fact that we managed to expand the survey beyond Europe and reach more than 100 countries with 13,000 respondents, which I think is a great outcome to have a global reach. And from a qualitative perspective, some of the members have been giving input early on to the questionnaire that was used for the survey. So that's how Global Commission also played its role in the Rare Barometer survey. And then I think a last point is about the evolving role of the Global Commission. When it was set up, the World Economic Forum, and we just had the last session, this year's session in Davos, recognized actually as part of their list of public-private partnerships, they recognized the Global Commission as what they called the leading lighthouse projects. And I think this analogy of a lighthouse is really also what describes very well the role of the Global Commission, because the Global Commission shines their light on best practice work in the community around the topic of diagnosis. So I think that's really where the Global Commission is playing its role. And I think Danielle will talk a bit more about where we're shining our light on a lot of case studies that are happening right now. So Danielle, over to you.
Great, thanks, Toon. Could you go to the next slide? I love the idea of the lighthouse. I think it is such an apt metaphor. And here again, we wanted to show and highlight some of the innovations in diagnosis that the Global Commission has really over the last year tried to synthesize into case studies that really, one, are making an impact on reducing that time to diagnosis, but really, two, have the potential to scale or be replicated in other contexts. So this was one of the keys for the Global Commission. And I invite you, I'll show the call to action, I'll show where the website, well, then you can access all of these case studies that include, could you just go back really quick to each of the case studies will include a description of the case. It will also include the key outcomes, success factors, and the learnings. So again, we wanted to highlight the good work and really get a little more tangible by talking a little bit more about Casa dos Herreros, which is the next slide, please. So this is also known as the Center for Comprehensive Care and Training in Rare Diseases. That again was a partnership between the advocacy group Casa Hunter, which is founded by Tony Daher, and Roberto Giuliani, who is a part of the Genetics for All Institute. And what they have done has been really, really exciting. Having a center of excellence, which again, the Rare Barometer survey has really identified as a key to reducing that diagnostic odyssey. The Casa de Rosas has reduced the time to diagnosis to an average of 58 days from first contact with the center. The national average in Brazil is currently about 5.4 years for patients. So you can see, again, just from those numbers, again, really making an impact in patients and families' lives. One of the other things, again, that Toon really aptly pointed out about the Global Commission is that really interested in how technology can play a role. And sometimes that might be really exciting things like AI that are new, but sometimes it's something very basic like WhatsApp. So one of the ways that this center has allowed referrals to happen is to allow patients to contact the centers directly via WhatsApp. And that, again, I heard from Claudia's beautiful presentation, is the referral is also part of the diagnostic delay. So it was also really gratifying to see a center that's really taken in some new ways that patients can directly get in touch with that center. And I guess the last statistic I would share on the work that they are doing is that they opened in 2023, and since then more than 2,500 people have contacted the center, and about 1 in 10 have really had comprehensive evaluations, medical professional and allied professional workups, and hopefully are again being that lighthouse, that beacon of light, to show how this model might be able to be replicated in other contexts in other countries. So the last slide, I just wanted the last minute to just show and highlight that we will be publishing from the Global Commission all of these case studies, which are available on the website in one single comprehensive report of all of the work that's been done. The QR codes that are there will bring you to both our website, where all of this information is held, as well as please asking everyone to join our LinkedIn page to follow, again, the great work in highlighting these case studies. So what we would like to continue to see is continued engagement, continue shining that light on the work that's being done. And again, really appreciate the connections between the Rare Barometer study and the work that's being done out in all over the globe. So thanks, Jessie.
Thank you. Thank you very much, Toon and Daniel. That's really amazing. And it's true that Brazil was actually one of the countries of the pilot. And with that pilot, we were able to reach out to more than 350 respondents, I think, in Brazil. And one of the changes that Toon was really talking about and adaptations that we did to the questionnaire itself was that actually the questionnaire, as it was disseminated in South America and based on the feedback from patient organizations there, we removed the question on the centers of expertise, because they told us that there was no center of expertise, and so there was no point in having the question there, because it would just confuse people, the respondents. So that's really a very good follow-up into to the work that was done in the questionnaire and in South America especially. So thank you very much. So we're almost due, and we will be 5 minutes left. So for those of you who can stay, we have just 3 slides left, and 2 of them will be presented by my colleague Raquel Castro. We'll
Maybe
talk
Jesse,
about
just
yeah,
one final
sure.
point. As Danielle was saying, so we're kind of launching our yearly report, but maybe also just to call on everyone, if you have a good case study, just submit it, because I mean, I think the membership is looking at collecting these case studies and also kind of showing the light on more of those. So feel free to send in yours.
Thank you for jumping in for this too. And yeah, so I give the floor to Raquel, who will just give you a very quick information how IRDiRC actually will be using the results of the survey and in EP event that we will hold on the 5th of March. Raquel.
Hello, good afternoon. I'm Raquel and I work within our public affairs team. I work more specifically with social policy, but today I get to tell you about our upcoming European Parliament event. And I also take this opportunity to extend an invitation to all those of you who might be able to come to Brussels on the 5th of March. And the event will be at the European Parliament in Brussels, hosted by MEP Stine Bosse and co-hosted with IRDiRC. So we are going to, so the event will mark Rare Disease Day, slightly after the date, as you can see, and it will focus on the impact of rare diseases and following the Rare Disease Day motto of more than you can imagine. And the program that we've built for the event goes through the journey of a person living with a rare disease. So we're going to use the results of this survey and also previous other surveys run through Rare Barometer to really build the narrative in a robust way about how it is to live with a rare disease, the different barriers and challenges across 3 different sessions besides the opening session, of course, where we will have some focus on diagnosis, on access to treatments, and also on holistic care and broader daily life participation. So we're going to use the results of this one, other surveys as well, to make it as robust as possible for policymakers, as compelling as possible. We're also going to add some anecdotal experiences. Obviously, each session will have a representative from the community who will actually be delivering these figures together alongside with anecdotal and their own experience, so to make it as compelling as we can. And so this is going to come up in March. So if you have not, we've started to send out save the dates. If you're interested in taking part, just get in touch with us and we can then make sure it will be in Brussels and not transmitted online, just so it's really for those of you who will be able to come to the European Parliament.
And I just jump in to say that, so as you can see, the last figures that are listed there are on daily life. And that's because my colleagues will be using the results of the very latest Rare Barometer survey that we have conducted together with Fatoumata and with Raquel. So the fieldwork was last year on the daily life of people with rare disease, and especially on social participation and independent living. And so those results, as Raquel said, will be used for the parliamentary event, but we will also have quite soon, on the 13th of February, another webinar to present those results. So you have the link on the top right of the page, and probably we can add it in the chat too, to register to this webinar, where we will present the results that we analyzed based on the close to 10,500 respondents that we had. Well, actually, we will focus on Europe, so 9,500 respondents, which is, again, quite high. And so Fatoumata and Raquel will be presenting those results in about 2 weeks. And of course, we will use them in the different meetings that we have and communications that we have. So I want to thank you all. And well, thank you first of all to the Rare Barometer participants who answered the survey and took the survey, and to all of those that I did list at the beginning who did participate in building the survey, and at least for 2024, to the partners and corporate donors of Rare Barometer. We will now stop this webinar. You will receive the recording. Please don't hesitate to share it. And for IRDiRC members, please know that the first part of this webinar especially will be used as desk work to prepare for a training that we will have in May at the IRDiRC membership meeting on survey and how to use the survey for the results of our surveys for action and for advocacy. So I want to thank everyone. I see a few faces still there. Thank you very much. And please don't hesitate to share. Well, first of all, to ask for specific results and to share how you've been using the results with us so that we can continue to inspire other people in the community in using them efficiently. Thank you very much.
Thanks, Jessie. Bye, everyone.